nasogastric tube feeding children and young people with restraint. This Nursing Times peer-reviewed article is read to you using an automated voice, so some of the words and phrases may not be as you would usually expect to hear them. The full version of this article, with citation, references, and illustrations, can be found at nursingtimes.net under the category Children's Nursing. Abstract. The number of children and young people with eating disorders admitted to general paediatric care is increasing. These patients occasionally require restrictive physical interventions, including nasogastric tube feeding with restraint if indicated. Guidance exists to support nurses caring for these children and young people. However, in our experience, the reality often falls short of what is recommended. Therefore, nurses need to be better prepared and supported to meet their own and patients' needs. The authors are Helen Sisson, Senior Lecturer in Children's Nursing, City St George's, University of London; Georgina Green, Clinical Education Facilitator, NHS Orkney; Erin Bergin and Fiona Girling, Lecturers in Nursing, Child, University of Hull, and Emily Calver, Staff Nurse, Hull University Teaching Hospitals NHS Trust. Introduction. Therapeutic holding and restrictive physical interventions are sometimes used during the care of children and young people with complex health needs or challenging behavior. Children and young people who have been admitted to the acute pediatric setting for treatment of an eating disorder may require more than therapeutic holding. They may need restraint or restriction of movement. The Restraint Reduction Network standards describe physical restraint as any method of responding to behaviors of concern which involves some degree of direct force to try and limit or restrict movement. However, any form of physical restraint remains a controversial intervention that could have potentially long-lasting and deleterious effects. Such invasive interventions can cause emotional and physical distress to the patient and their family. It can also upset the staff involved, and reconciling this with the need to provide nutrition to the patient can present a moral dilemma. This article considers the guidance available for paediatric nurses in the acute care setting, as well as making recommendations to improve practice. Restraint is part of a multidisciplinary process that includes consent, risk assessment, briefing, communication, intervention, documentation, and debriefing. However, this article focuses on the intervention aspect of restraint and its challenges. The term restrictive physical intervention is increasingly replacing restraint. However, this article refers to restraint because this is the term most frequently used in the relevant guidance. Assessment of eating disorders. The most common types of eating disorders are anorexia nervosa, bulimia nervosa, and binge eating disorder. Children and young people can be at risk of developing an eating disorder for a variety of complex reasons. It can occur at any age, but the risk is highest in people aged 13 to 17. Patients' risk and subsequent need for acute care admission are often assessed by GPs, eating disorder clinics, pediatric assessment units, or emergency departments. Acute symptoms of an eating disorder are bradycardia, postural tachycardia, dehydration, a systolic blood pressure that is less than 90 millimeters of mercury, or less than the 0.4th percentile, a core temperature of less than 35.5 degrees Celsius, evidence of severe malnutrition, vomiting, or laxative abuse, hypovolemia, hypokalemia, hyponatremia, or other electrolyte abnormalities, hypoglycemia, mental health or safeguarding risk. Accordingly, on admission, children and young people are required to undergo investigations, including electrolyte blood testing, weight and body mass index measurements, and psychological assessment. Admission to a pediatric medical ward requires a coordinated multidisciplinary approach to deliver the necessary evidence-based care. This should include input from child and adolescent mental health services, dietitians, and pediatricians. Treating eating disorders. Management of the patient depends on clinical presentation. The National Institute for Health and Care Excellence recommends that patients are offered approved psychological treatment at the earliest opportunity and that a multidisciplinary approach is used. Most commonly, children and young people with an eating disorder are nursed under close observation in open bays, and treatment includes daily blood tests, bed rest, supervised meals, and calorie-counted meal plans. Ideally, children and young people should be treated in specialist eating disorder units. However, some are cared for on paediatric wards, and those with extreme physical health issues may be admitted to a medical ward. In most cases, children and young people do not resist the treatment provided. However, if a patient is deemed to be in a life-threatening situation due to lack of nutrition and is refusing oral refeeding, a multidisciplinary plan should be developed and a decision made about detaining them under Section 2 or 3 of the Mental Health Act 1983. Treatment can be administered against the patient's wishes under Section 63 of the same Act, under their clinician's direction. If a patient is not detained under the Mental Health Act 1983, a capacity assessment should be carried out. The Mental Capacity Act 2005 sets out the circumstances when a patient's treatment refusal can be disregarded to prevent harm to themselves or others. In the UK, there are a number of national guidance documents for managing eating disorder, meaning the guidance for involuntary treatment of eating disorders in children and young people varies. Each organisation has its own guidelines, which should reflect the national guidance and with which staff should be familiar. The Royal College of Psychiatrists' 2023 guidance states that nasogastric tube feeding with restraint is indicated as a life-saving intervention. This should be delivered in the least restrictive way possible, and a staff member should be present who is trained in safe restraint techniques. This presents a challenge in acute paediatric settings, where staff are not often trained in these techniques. Both the government's and the Nursing and Midwifery Council's guidance agree that nurses involved in the restraint must have completed the recommended training to ensure they are working within their limits of competence. Restraint can cause physical and psychological trauma for children and young people, as well as workforce trauma for health professionals. Training is therefore vital for the safety of the patient and to reduce the risk of physical injury to all involved. The Royal College of Nursing recommends that restraint should be treated as a last resort only, and it should strictly adhere to the Mental Health Act 1983 and the Children's Act 2004. It also states that organisations should undertake risk assessments to identify staff needs and deliver setting-specific training on alternatives to restraining children and young people. Most recently, in 2023, the NHS published guidance that encompasses aspects of the above documents and contains multiple resources for children and young people, families and staff. It highlights that children and young people with a life-threatening eating disorder may be at risk of poor outcomes when admitted to general paediatric wards, and that nasogastric tube feeding with restraint should only be considered in the absence of other treatment options. Delivering any treatment against a patient's wishes is extremely challenging for children's nurses, who strive to be advocates for children and young people. We expect to use our knowledge of GILIC competency and work within the Nursing and Midwifery Council's 2018 standards to allow a patient to consent to their own treatment. When they expressly withdraw this consent, it is vital to establish that treatment is in their best interest and to preserve safety. Current practice and its impacts. The number of hospital admissions for children and young people aged 18 years and under with an eating disorder in England increased from 3,541 in 2015-2016 to 6,713 in 2020-2021. This trend appeared to escalate during the COVID-19 pandemic. Where restraint is required, nasogastric tube feeding is not only resource-intensive, but distressing for children and young people, families and staff. The lack of resources may explain why a multidisciplinary approach is not always possible. However, training for the staff involved with this procedure may help ameliorate some of their distress. Furthermore, Fuller et al. Recommended that parents should not be involved in restraining their child because they are not trained. In our experience, most families are not present for restraint procedures by their own choice. Guidance places a strong focus on the patient's privacy and dignity, mirroring the Nursing and Midwifery Council's 2018 standards. However, in our experience, transferring patients into the treatment room to give feeds offers privacy, but often eliminates any dignity. It frequently happens against the patient's will, in view or earshot of other children and young people and families. Sedation can be used to reduce children and young people's pain and anxiety during certain procedures. Some guidance, such as the NHS's 2023, recommends staff consider sedation during the insertion of nasogastric tubes to reduce distress for the patient or if they request it. However, they would require restraint for sedation, further prolonging the process. Furthermore, there is a risk that sedation would not be effective enough to ease the process, as heavy sedation would be contraindicated with feeding due to the risk of aspiration. A survey of 99% of the UK's child and adolescent mental health units and eating disorder units, number equals 134, identified that only 43% were able to provide nasogastric tube feeding with restraint. This was partly due to a lack of training and because it contravened the unit's therapeutic ethos. These findings resonate with our experiences in the general medical setting. Although the intervention might be a life-saving act, it creates substantial feelings of apprehension beforehand and guilt afterwards. Building therapeutic relationships with children and young people and their families is fundamental to our role, and undertaking this extreme physical intervention against their will is likely to complicate these relationships. Kodua et al. Explored the experiences of nursing assistants who had been involved in delivering nasogastric tube feeding with restraint for children and young people with anorexia nervosa. The nursing assistants reported experiencing anxiety, guilt, and anger, as well as physical exhaustion and physical injury, often because of patients' aggression. Talking with others and detaching from the process were reported as important coping strategies for the nursing assistants. The NHS and Fuller et al. Also recommended that a staff debrief follow each intervention, with Fuller et al. Acknowledging that some staff may require additional support beyond this. In our experience, debriefs and additional support do not occur regularly due to competing workloads. Therefore, formalizing this process by identifying appropriately protected time is important. Clear, well-structured care plans are vital when treating children and young people with an eating disorder. The Royal College of Psychiatrists suggests weekly review meetings for all frontline staff to discuss emerging issues and formulate a treatment plan that safeguards both the patient and staff. There is a strong emphasis on the importance of handover between staff, with the aim of a consistent, collaborative approach. For each feed, any restraint used should be clearly documented. The need for nasogastric tube feeding with restraint should be reassessed frequently, based on findings such as electrolyte blood tests and vital signs scores. However, in our experience, the care of patients requiring nasogastric tube feeding with restraint does not always reflect the discussed guidance. The Restraint Reduction Network advises that staff training should focus on avoiding restraint by using techniques involving conversation with the patient. Conversely, however, the Royal College of Psychiatrists instructs staff to avoid prolonged negotiations with children and young people about their treatment. Burton highlighted that the complexity of eating disorders causes professionals difficulties in understanding them. This might explain the challenge of training paediatric nurses, who are trained primarily in physical health conditions, to competently and confidently care for children and young people with eating disorders. It may also explain the opinion we have observed among paediatric staff that these patients should be on mental health wards rather than general paediatric wards. Broomfield et al. Assessed current service provision, alongside the increase in eating disorder presentations in paediatric settings, concluding that the status of these settings may have irreversibly changed. As a result, staff training, facilities, and multidisciplinary services may need to adapt appropriately, requiring nurses in these settings to be better prepared and supported. Recommendations for change. The rise in admissions to general paediatric areas has substantial consequences, both for the environments and the nurses working in them. We, therefore, highlight the following set of recommendations for change. The involvement of mental health staff in the delivery of nasogastric tube feeding with restraint should be embedded as usual practice. The Royal College of Psychiatrists instructs that this intervention requires mental health staff trained in safe control and restraint techniques. However, in our experience, multidisciplinary input is variable and frequently lacking during the feeding process. This is most likely due to staff shortages in the mental health workforce. Staff training around the feeding process, including safe restraint techniques, should be prioritized. Staff may feel coerced into participating in the feeding process without receiving training. However, this contravenes their fundamental nursing values and raises concerns around competence and both staff and patient safety. Published guidance does not specify frequency of training, but we advocate for mandatory updates to ensure practices remain current and evidence-based. Staff experience of nasogastric tube feeding with restraint. National guidance is unanimous in its recommendations for a multidisciplinary approach to nasogastric tube feeding with restraint. However, in our experience, although we have observed increased multidisciplinary presence during decision-making and treatment planning, the procedure itself is still being undertaken solely by paediatric nurses. Staff who have not been trained in safe restraining techniques have also anonymously shared experiences when they felt coerced into participating in the procedure.
Feeding children and young people via a nasogastric tube under restraint was very stressful for all parties. It was physically and emotionally exhausting, and there was a conflict between knowing I should be working within my limitations and being told it was okay to do by senior management, who would highlight that the child would deteriorate further if this was not done.
As a senior nurse in charge, I declined to support other staff to restrain a child requiring a nasogastric tube feed. I had no training, and I wanted to work within my own limitations. I felt comfortable with my decision, however, felt pressure to carry out the task to support the team.
Opportunities for staff to debrief after feeding should be normalised. This allows them to reflect, with a view to improving their practice, and reduces any psychological harm they may experience. His Majesty's Government recommends time for patients and staff to reflect separately, following incidents of restraint. This poses further staffing and logistical issues, requiring time to be allocated not only for the refeeding process, but for reflective time afterwards. The increase of eating disorders among children and young people means that caring for them in the general paediatric setting is now more commonplace. Paediatric nurses should be prepared to care for these patients in the same way that their education trains them to care for children and young people with physical health problems. A review by Salzman, Eriksson and Dahlen identified that among nurses who care for children and young people with anorexia nervosa, those who have increased knowledge of the condition and a person-centered, committed attitude have a better relationship with patients. This may also improve patients' adherence to treatment. In our experience, nurses in the general paediatric setting do not prioritize patients with an eating disorder. Further research into these nurses' perceptions would provide greater insight into how best to prepare and support nurses who participate in nasogastric tube feeding with restraint, which may also improve children and young people's experiences and outcomes. Conclusion. There has been an increase in admissions of children and young people with an eating disorder to general paediatric settings. It is vital that they receive care based on published guidance, and although guidance around nasogastric tube feeding with restraint is plentiful, resources to support practice are not. This practice is unfamiliar to nurses in the general paediatric setting. However, because it is becoming more usual, strategic action is required to ensure an evidence-based approach. The full version of this article, with references and illustrations, can be found at nursingtimes.net under the category Children's Nursing, along with our AI search facility, Ask Nursing Times, which allows you to explore the subject further. Thank you for listening.